Hello everyone, myself Sakshi Pal, a student of second year of Bachelor of Physiotherapy at Marwadi University. Today we'll be discussing a topic of microbiology about a serious bacterial infection which is known as melioidosis. So what is melioidosis? Melioidosis is a serious bacterial infection caused by the causative organism known as Burkholderia pseudomelia. It is a gram-negative bacteria. It is also known as great mimickers disease because it mimics many diseases such as pneumonia, TB, osteomyelitis, septicemia, etc. And it is often very difficult to diagnose it. It is the mode of transmission of this disease is through contaminated soil and water. It is often common in Asian regions such as India and Thailand. Now, what is melioidosis? Melioidosis is a serious fatal infection, highly severe and potentially fatal clinical pathology caused by environmental pathogens. Causative agent is gram-negative bacterium Burkholderia pseudomelia. It is also known as the great mimickers disease since it is highly prone to misdiagnosing due to clinical features mimicking tuberculosis, sepsis, and pneumonia. History and epidemiology. History. In 1912, firstly it was identified by a pathologist named Alfred Whitmore, Rangoon and Burma. Upon him, classically termed as Whitmore's disease in historic medical literature, Indian context, rising recognition and diagnosis across subcontinental clinical centers. Critical note, it has very high mortality rate if therapeutic causes are delayed. Now let's look about the causative organism Burkholderia pseudomelia. It is gram-negative bacillus rod shaped. It has active mortality, it requires oxygen and intercellular persistence, which is capable of residing inside phagocytes, shielding itself from immune clearance. Characteristics of this organism is when you stain it, it is gram-negative and rod shaped. It is resistant to antibiotics. Bipolar staining, it has safety pin morphological appearance. Oxidase reaction is positive, distinguished from other enterobacteriosis. Spore status, it is non-spore forming, yet highly resistant in nature. Habitat of this bacterial infection is agriculture field, which includes damp soil, rich mud, and flooded rice cultivation paddies, represent key ecological reservoir. It is also present in stagnant water, persistent in surface water bodies, marshlands, open drains, and contaminated agricultural pools. Next is monsoon fluctuations. When there is heavy rainfall, cyclones dynamically pull the organism to upper agricultural soil surfaces. Mode of transmission of this bacteria is through microscopic skin cuts, abrasions, or direct wound contamination. Next is through inhalation when the person inhales dust clouds, mist droplets created during storms. Third one is ingestion risk by drinking uncontaminated water. High risk population who are at the risk of this disease. The people suffering from diabetes mellitus, people having chronic lung conditions such as COPD, and the people working having occupational hazards such as farmer and construction workers. Pathogenesis path. What is the pathway of this pathogen? Basically, it enters our system through inhalation or ingestion. It divides under the host, spreads through blood, causes multiple organ abscesses or multiple organ failure, and causes systemic sepsis. Clinical features and target organs. Target organs in respiratory tract, it causes pneumonitis, consolidation, TB. In skin and visceral tissue, it causes multifocal ulcer, liver and spleen abscesses. In musculoskeletal system, it causes osteomyelitis, septic arthritis, and joint pain. Common patient presentation. What are the symptoms of the patient suffering from this? Are fevers and chill. The patient suffers from intermittent high-grade fevers, productive cough accompanied by chest tightness and shortness of breath. Somatic pain, severe septic joint pain. Now, how we can diagnose it? since it is very difficult to diagnose it. First is through culturing sputum and blood of the patient suffering from this disease. Then by performing rapid polymerase chain reaction, which is PCR. Then serology and by through screening and stains. Next is the management of this disease. It happens in two phases. First is the intensive IV phase, which is for 10 to 14 days. Next is eradication stage, which is for 3 to 6 months. In intensive IV stage, we have aggressive administration of high dose of intravenous bactericidal agent. One of them is ceftazidime. Next is eradication stage, prolonged treatment regime designed to eradicate cellular latent reservoir and reduce the risk of clinical relapse. Now, critical system complication. The mortality rate of this disease is 40% due to septic shock. It causes multi-organ failure and acute respiratory distress. Preventive measures, how we can prevent this disease. First, the people working in agriculture or construction site, we can tell them to wear protective footwears, heavy duty gloves to provide barrier for hand exposure, safe water intake to intake safe water, not the contaminated water. What as a physiotherapist we can do? We can help them in rehabilitation like respiratory chest care, facilitate airway clearance through postural drainage, musculoskeletal mobilization to improve range of motion exercises, endurance restoration through aerobic exercises. Conclusion is early identification, so the mortality rate decreases. Early identification is key to mitigate systemic mortality before multifocal septic shock. Next is synergistic approach to not only use drugs but also use physiotherapy approaches. Next is what as a physiotherapist we can do. As a physiotherapist, we can maintain their pulmonary wellness, safeguard joint function, and expedite patient reconditioning. These are the references. Thank you for watching.